So next speaker is Dr. Emilio Poggio. Dr. Poggio has been in Cleveland Clinic, Ohio for more than 20 years. He has been the medical director for around 12 years. He has multiple APOL1 grants. He's actually one of the PI of the APOLO studies, and he will tell us, continue the discussion about, do we need to check APOL1 in living and deceased deceased donors? Thank you, Dr. Poggio.
Thank you very much, Tarek, and everybody for inviting me to this meeting, and yesterday to spend the day at WashU, which was a great experience for me. Okay, so let's talk about this. As we all know, this is a well-known paper where we learned about 10 years ago that the risk of developing end-stage kidney disease is much higher in donors of African American race compared to Hispanics and white people. We also learned a few years ago from a single center data from Michigan, Detroit area, Mona Roshi, and also Mariela Ortigosa. They call African American donors back, they genotype them, and then they look at their outcomes. 136 African American donors, 14% were APOL1 positive, and they had 12 years of follow-up. Here are the results. As you can see here, prior to donation, I'm sorry, I don't have my glasses and I don't see this very well, but those are low risk in the first group, had a GFR that was slightly elevated compared to those who were APOL1 positive. This is a pre-donation, and this is estimated GFR. But then after 12 years, you can see that the GFR after a nephrectomy, of course it decreased, but you can see that in this group, the GFR remained higher compared to the GFR in the group that were APOL1 positive, and in fact, 2 of the donors were on dialysis. Here, if you divide by CKD stages or by GFR stages reflecting GFR levels reflecting CKD stages, let's put it that way, you can see that more African American donors who were APOL1 positive had a higher percentage of CKD stage 3 or more. And this is the slope of the GFR after donating a kidney. So there's some data there that African American donors who are APOL1 high-risk variant had lower or very inferior outcomes in regards to kidney function and end-stage kidney disease. So assuming end-stage kidney disease is more common in African American donors, that the APOL1 risk variant mutation is highly associated with kidney disease, and that we have some data in living kidney donors, the one I just showed, should we systematically test for APOL1 gene mutations in living donors? That's the question. And the answer is not that simple. And why is not that simple? It's not simple because most living kidney donors do not develop advanced CKD. A known long-term risk of APOL1 high-risk variants in African American living kidney donors, with the exception of that data that I showed. There's unknown implications of not donating a kidney versus future potential risk of developing kidney disease. There are concerns to negatively impact transplantation in an already disadvantaged population, and from the recipient's perspective, the risk of not being transplanted may be higher than the risk of getting a kidney that is APOL1 positive. So this is a nice perspective that Peter Rees wrote 10 years ago now about the harm we can cause to donors from declining them as a potential donor, simply because we think that there's risk of developing a condition. So we have to keep that in mind too. What do U.S. transplant centers do? There are several surveys. This is basically the first one. The second one. This is actually Krista is in this one. This, I think it was a ASD Living Donor Community of Practice. And 13% of the programs perform APOL1 genotyping on all African American donors in this country. This is from 2017. The practice may have changed, likely changed. Another 32% of the programs perform the test in selected cases, and 55% of the programs do not even test. Some respondents perform this testing for younger African American donors only, And among the programs that they obtained this test, 52% report that the high-risk APOL1 genotype is an absolute contraindication. Another half of the respondents says it is a relative contraindication. A different study, more recent, but the survey was about a year later than the previous one, 63 transplant centers, that they at least did 10 living kidney donors a year, so they have more experience, so they are larger transplant centers. And those centers represented 69% of the African American living kidney donors in the country. The data is from September 2018. 52% of the transplant centers responded, 90% of nephrologists and 10% surgeons. And these are the several questions they ask. The first one is if your center does not currently offer APOL1, what are the reasons? The first one is there's not enough information. 70% of the centers answer that. They were concerned about reducing access to living kidney donor transplantation, is another 23%. Then they ask if your center does not currently offer APOL1 testing or use a test resulting in evaluating prospective living kidney donors, under what conditions you would do it. The answers were when data becomes more available, 60%, they want more data, and when we are able to determine which people with 2 risk alleles will develop kidney disease. And also there were concerns about insurance impact on the insurance ability to get insurance in the future. If the center does obtain APOL1, what do they do with the information? They discuss the risk with the potential donor. The center and donor candidate make a decision together. That's half of the centers. And they exclude the individual as a donor by only their decision, 43% of the centers. Or they provide the potential donor with formal genetic counseling, and then they decide. Last question, if your center obtains APOL1 test results for a potential donor and the person has 2 risk variants, do you encourage them to share results with other people, especially with a primary care physician, 50%, and no, 37%. So it's another survey. Now, the living kidney donor view, there's also a survey there. This is a nice study too. 23 donors were interviewed. 96% of the donors, these are actual donors, reported that transplant centers should offer APOL1 genetic testing to all African American donors. So the donors themselves, prospective donors, really want to be, at least have the information and be offered the test. 87% would have been willing to undergo the APOL1 testing before donating, so not everybody. And 61% of the donors, these are prospective actual donors, would have donated even if the donor had 2 risk alleles for APOL1. So a significant number of them, when they decide to go and donate, and that's my experience too, they're already committed to donate the kidney. They already made up their mind, but they still want to have the information. What do organizations and societies recommend or suggest? This is the AST expert conference recommendations. Mandatory testing is not recommended. This is from 2017. Inform potential African American donors of the association between APOL1 and kidney disease in the general population. Inform the potential African American donors that the testing is available. Inform and educate the donor that there are risks associated with genetic testing, not related to developing CKD, but genetic testing in general. And if performed, APOL1 results should be integrated into the entire donor's profile, including demographics and other considered comorbidities, not being the single reason why you decline a donor. 2017, KDIGO recommendations, APOL1 genotyping may be offered to donor candidates of sub-Saharan African ancestors, so basically it leaves it up to the transplant center. And donor candidates should be informed that having 2 risk alleles increases the lifetime risk of developing kidney failure, but that the decision about donating a kidney is up to the team. So you can see that they are very vague, and basically you can do what you want. I mean, not what you want. What I'm saying is the transplant center can decide the approach they want to take. This is another group, a more recent, an expert panel opinion. So they say similar than the other 2 recommendations: inform and educate the donor, consider testing for those who are younger or higher risk. Donors who wish to donate regardless of results, they should be allowed to proceed as long as they are good candidates. And isolated findings of positive results should not be used alone to determine donor candidacy and ensure decision making. So we're going to learn more about this. We have here in the room Krista and Dan, and I'm sorry if we are part of APOL1. We've been working with this for 6 years. And then Krista is also involved in the living donor extended time outcomes little, which is related to APOL1, but it's not part of the study. But we're going to learn more in the upcoming years about the risk of APOL1 risk alleles in donors, maybe, but in recipients as well. 2 words on whether African American deceased donors should be tested. We have data from retrospective data from 2-3 large transplant centers, where you can see that the outcomes of recipients of kidneys from donors, deceased donors who were APOL1 positive, have inferior survival. And they postulated that now in KDPI, which includes the race African Americans in the model, and increases your risk by 17% if the donor is African American. They proposed with a new model, I'm going to simplify here, that if the donor, independent of race now, is APOL1 risk allele, high risk for kidney disease, that is used instead of race in the KDPI to determine the quality of the organ. So we will learn all this when we have the results from APOL1. Should potential African American kidney donors be routinely tested? The answer is no. Should be informed, educated, and offered testing? The answer is yes, a short answer. If the transplant center adopts APOL1 genetic testing, protocols should include education about what this is known and unknown, benefits and risks, and plans to include prospective donors in the decision making. Thank you very much.
Questions?
Any thoughts about Emilio, the therapeutics in the context of transplantation?
Yeah. So in the donor or recipient?
Either, wherever you think it may apply.
Well, I think let's say if we have treatment in the future, I think the most important thing here is, in my experience, I've been doing living donor evaluations 2 or 3 a week for 20 years, or maybe 1 to 2. When donors come, when you have them sitting in front of you, I've only seen once or twice where the donor walks away and says, well, after what you told me, and this is independent of APOL1, I will not donate. They already committed. But if we have treatment in the future, I think it would be much easier and much more straightforward. And especially if we can survey, I think the most important thing is to follow these people closely. And at the early sign of albuminuria or anything, boom, you interfere. But I think that's going to change a lot.
Thank you so much.
All right, you're welcome.
Great.